Hello and welcome to this MIMHtraining.com presentation on current issues in suicide prevention. I'm Tom Pansella with the Missouri Institute of Mental Health. Thanks for taking the time to take this training program. We're joined today by Dr. David Jobes. And Dave is a professor of psychology. He's part of the clinical faculty and co-director of clinical training at the Catholic University of America. His research and writing in suicide has produced numerous publications, including 3 books on youth suicide. His newest book on CAMS, The CAMS Approach to Suicide, was published by Guilford Press in 2006. He's an internationally recognized suicidologist, and he's spoken to a broad range of audiences. He's frequently interviewed with the media on the topic of suicide. He's past president of the American Association of Suicidology and is the recipient of that organization's 1995 Edwin Schneidman Award in recognition of early career contribution to suicide research. He served as a research consultant to the Centers for Disease Control and Prevention and was a consultant to the Institute of Medicine on the National Academy of Sciences. He's currently a consultant to the Department of Defense and Veterans Affairs and has previously testified before the U.S. Senate, a subcommittee on the topic of youth suicide. He's a board-certified clinical psychologist from the American Board of Professional Psychology, and he maintains a private clinical practice and forensic practice at the Washington Psychological Center. So Dave, thanks for joining us today.
Thank you, Tom.
Got a lot of experience in this field. So what prompted you to go into psychology?
When I was an undergraduate, I was looking for a major that would give me a sense of direction and purpose and passion, and my first psychology course was the beginning of a track in that direction. I really have just loved the topic area. I've loved the idea of helping people. It's just been compelling for me all along.
Well, take us from there then to how you got into the field of suicide prevention.
Well, from an undergraduate degree in psychology, which you can't do much with, I knew I had to go to graduate school. So I ended up getting into graduate school at American University in Washington, D.C., and my major professor was a professor named Dr. Lanny Berman, who's now the executive director of the American Association of Suicidology. And Lanny was and is a prominent suicidologist and was immersed in the field, and I just started taking after a mentor. And really, beyond just getting into it and finding a way to do research in it, it became my absolute passion. From my master's thesis to my doctoral dissertation, it's just been a focus for my professional track.
So why is it a significant issue? I mean, why is it that it's something that we need to be talking about?
I think leading cause of death. It's a compelling topic. Lots of perspectives on this, but my view is that most people that want to die or think they want to die by suicide really want something else instead. They want to end their suffering. They want people to know how much they are struggling. Most suicidal people have lots of reasons for being suicidal. Ending their biological existence may not be at the center of it, as peculiar as that may sound. So I really feel, and the treatment research that we do is about offering alternatives to suicide. Because for some people, they don't know what else to do. And in that mind state, they can come to think that this is the only thing I can do. And the clinician in me and the researcher in me says there's always lots of other things you can do short of taking your life.
And I think in general the field of psychology is hard to separate your personal from your professional sometimes.
Sure.
Is there an area about this that disturbs you the most?
Yeah. I mean, there are many areas. I mean, I think the one that's sort of unavoidable is the impact on families, parents, siblings. This is a unique kind of death, and virtually everybody that has lost someone to suicide somehow feels responsible, somehow feels like there's something they should have or could have done. I think that that's particularly disturbing because you see it. You see, when you come to a conference like this or you go to different meetings, you see parents who've lost kids, and it's pretty much about the most devastating thing that a parent can go through. Aside from that, I think there's just the thing I spoke to before, which is that the tragedy of people not knowing what else they can do and getting into a mind state where they really think that this is it. The founder of our field, Ed Schneidman, used to say it's a bad idea to kill yourself when you're suicidal. And what he meant was you're probably not thinking straight, you're probably depressed, your thinking is distorted, you're probably not reaching out to others sufficiently, and we're talking about life and death here. These are the fatalities of mental health care.
Now, there's a lot of stigma around the mental health field in general.
Yeah.
Let's talk a little bit about it in relation to suicide. So, is there a stigma that exists around getting help or even talking about it? And then have you seen a change? You said previous to our conversation that you've been doing in this field for about 27 years.
Yeah.
And so have you seen a change in that stigma?
Yes and no. I think there is an appreciation of the importance of mental health on some levels, but there's also, I think mental health is the butt of a lot of jokes and teasing in the media and in sitcoms and the like. I think that, it's what I find is that there's a wariness or a disrespect or a common sort of punchline that's about mental health professionals being more unstable than their patients. And then somebody needs a mental health professional, and suddenly it's all very serious. So I think we're very ambivalent about mental health care. It's not on parity with physical health care. Congress has passed a law to make mental health parity in insurance companies' eyes equal to physical health issues, but that discussion is far from being truly equal. What will be reimbursed for physical health is not what will be reimbursed in mental health, even though it's supposed to be the law. So we do see a struggle. We do see a tension with people recognizing that there's an important role for mental health professionals to play, but there's still a wariness and a fearfulness about it. I'll tell you, I've been doing a lot of work with the military lately, and whatever stigma we see in general American culture, it's 10 times more profound in the military. And we have suicide rates now in the military that are the highest in recorded history. So stigma is alive and well. There's major campaigns and efforts to attack it, but it's a major source of concern for suicidologists.
We're in a part of the country that has large tracts of rural land.
Yeah.
A few urban centers scattered, but a lot of rural areas, and so access to services is sometimes difficult.
Yep.
It's also difficult in the economic climate that
Absolutely.
we're in. And the economy tends to lead people to need more services sometimes. So you just talked about the military problem getting worse, but is the problem getting worse in general? Are you seeing a change in numbers?
It depends how you look at the numbers. I mean, suicide rates tend to wax and wane to some degree over time. They've remained relatively stable. This is the 11th leading cause of death. That's been true for a while now. There are trends, like we see in the military right now, where the infantry and the Army and the Marine Corps for the last 4 or 5 years have really been trending up significantly high. So you do see trends like that. You see trends in subgroups, some groups of adolescents or young adults or different minority groups. What's been frustrating, I must say, is that the numbers stay relatively stable. And there's a lag between what we know about completions and when they actually get officially reported. So, for example, in the current climate, we've gone through an economic downturn, a struggle the last few years. The data on suicides lags about 3 or 4 years, so we don't really know if the economy has had an impact on our completed suicide rate, and won't for a few more years because there's this lag time. So, on the one hand, the data remains relatively stable. On the other hand, we have seen impact on some of our interventions. It's a tough nut to crack. At the same time, at the individual level and sort of at the systemic level, we've certainly seen interventions that we think make a big difference.
So the interventions, what are you treating?
Well, there are different views on this. There are, I would say, 2 major camps. One is primarily focused on psychopathology and treating mental disorders, and I'm all for that. I have no issues with that. But what's interesting is that the research really shows that a more focused treatment of suicidal thinking and behavior probably has more value than focusing on mental disorders per se. Now, these aren't mutually exclusive, of course, but if I'm a psychiatrist or a psychologist or a social worker, mental health provider, and I'm focusing on treating a depression versus focusing on the ideation and behavior that's suicidal in nature, I may be a little bit off the mark, because there are millions of Americans who are depressed, never have a suicidal thought. So suicide is not equal depression. Now, when we look after the fact at people who've died by suicide, a good percentage, probably the majority of them, are depressed. But depression doesn't simply account for what drives suicidal behavior. It's unique. There are people that go through horrible experiences, never have a passing thought of suicide. There are people who you look at and think, that person shouldn't be so bad off. maybe plagued with thoughts of suicide. So I'm in the camp that really focuses on those people that think, I should kill myself as a means of getting my needs met, or ending my suffering, or whatever that in that person's mind makes sense to them. So the treatments that we do really focus on those individuals, frankly, independent of their diagnosis. They could be depressed, they could be schizophrenic, they could have bipolar disorder, they could have anxiety disorder or substance abuse. We care about those, but we care about those only as they relate directly to this person being suicidal. So the approach that my group's developed really focuses on what the patient believes, or what we call the drivers. What makes you want to kill yourself? If it's your marriage falling apart, or it's your depression, or the fact that you're unemployed, that tends to be what we focus on in our treatments. That may co-occur with psychopathology and focusing on mental disorders, but we're much more focused on the ideation and behavior.
Can you talk a little bit about your treatment approaches then? Because it seems like it would vary a great deal.
It does, and the approach I'm describing and what we do research with is called the Collaborative Assessment and Management of Suicidality. So the CAMS approach is a different kind of intervention because it's not a new psychotherapy. It's a therapeutic framework where the clinician really engages on this topic very differently. Some people in the field have really held the view that the primary way that mental health providers deal with suicide risk is to shame and blame the patient and to try to outmuscle them, so to speak, saying you can't do this, we're going to hospitalize you, we'll commit you against your will. And what I've come to know, after all these years of studying suicidal people, is that suicide is intimately connected with issues of power and control. So for a suicidal person, this is one thing they feel they can do. And then they encounter a mental health professional who says, no, you can't do this. We're not going to let you do this. So that creates a power struggle. So we end up fighting about whether the patient can or can't do this, when in fact the patient can. And we no longer live in a society or a culture where we can put people in hospitals indefinitely. Lengths of stay in inpatient units have plummeted over the last 20 years. So we really can't make somebody, or even create environments that are 100% suicide proof. So the CAMS approach really kind of acknowledges that and basically tries to engage the patient differently. We basically say, you can kill yourself. As a mental health provider, the law says I can't let you. But before we get into that struggle, let's talk about whether this is a good idea or not. Now, I've got my bias about this, but for you, this may make a lot of sense. So the question at hand is, if it's such a good idea to kill yourself, then what are you doing here with me? Because I'm not going to be on board that train. You're probably here with me because you're ambivalent. And if you're ambivalent, that's a good thing from our view, because then we can engage you around your reasons for wanting to live and your reasons for wanting to die, and make the case for how we could find a way for you to work your way out of this place that you're in to make your life livable. Everything to gain, nothing to lose, and that's sort of the philosophy of this. And for a lot of suicidal patients, that seems like a reasonable, respectful stance. I'm not making them feel bad, I'm not shaming them for these thoughts and feelings. So when we have this kind of philosophical set, or this kind of a way of looking at it, then literally what we do is we take a seat next to the patient, just like I'm sitting with you, and we go through an assessment together, because the patient is the expert. I'm knowledgeable and I'm trained as a clinician, but the patient is the expert, and that patient walks us through various kinds of assessment questions that we do together. And in the process that we discover, what's at the core of this person's suicidal struggle. And when we transition into treatment and intervention, we're going to try to stabilize you, and we have interventions that we think can stabilize you and give you a coping skill set that you didn't have before you came. And we're going to develop that crisis response plan with you, so if you do get in trouble, what you should do and how we can help you. But then the treatment's going to focus on what makes you want to kill yourself. And that's defined by you, the patient. And so that may involve medication, or that may involve, in the VA system, that may involve having you go to the PTSD group, or getting the some work done in the pain clinic. So we can farm out those treatments, or maybe I can provide those treatments. But the idea is, if we can stabilize you and giving you a new skill set, a new toolkit of psychological coping skills, and treat what makes you suicidal, and the capstone of the treatment is to really think about your existential purpose and meaning, That may sound abstract, but if we don't have purpose and meaning and reasons for living, for any of us, life can seem pointless. So there is actually a part of this treatment, this intervention, where we talk about, what do you want to live for? And if you've got nothing on that list and you're mostly preoccupied with what you want to die about, then we're going to work to create a little bit of a list there. And oftentimes that involves your family, that involves your faith, that involves your vocation. If you hate your job and you hate your wife and you hate yourself and your kids don't talk to you, it's a pretty miserable state. So our view in the CAMS approach is to tackle that head on and try to change those things we can change to give this person a fighting chance.
How long do you need? Where are people when they come to you?
Well, it varies. I can tell you from the research standpoint, we need about 3 months. And now I'm putting on my researcher hat, but when we do clinical trials, a lot of this highfalutin talk has to get sort of boxed up and made into like a treatment package. And the package that we have is about a 3-month intervention. And we've seen, and other groups have seen, that when you engage on suicidal thinking and behaviors in the ways that I'm describing, not just in the CAMS approach, but in cognitive therapy or dialectical behavior therapy or interpersonal psychotherapy, when you really grapple with these kinds of issues in these kind of therapies, it's remarkable how many people will stabilize and move off the radar screen of suicide, sometimes in our group, within 6 or 8 sessions. If you've meaningfully engaged in this topic, if you've helped them stabilize, and then you're treating the things that make them suicidal, invariably, Tom, that instills hope. And where there's hope, there's mood that follows, there are possibilities, there are prospects, there are options that were previously unavailable. So the very nature of the intervention is meant to create a strong alliance, which we know drives good outcomes. But it's also to engage the patient as not a passive recipient of treatment, but as an active collaborator in their own care. In the CAMS approach, we talk about the therapist and the client co-authoring their treatment plan. As the licensed professional, I'm responsible for that documentation. But if you're my patient, I want you on board with this because it's your life. And I'll be visiting with you in our sessions, but you've got to make this life livable. And that means you've got to be a part of the treatment.
You're kind of shifting back and forth between
Sure.
researcher and clinician, and
Yeah.
I think that's significant here because the research perspective says, how do you know that it's working? I mean, people leave your program at some point.
Yep.
What kind of follow-up do you do, and what kind of research has backed this up now?
Well, I mean, for starters, there is remarkably little research on the treatment of suicide risk. There are about 43 studies right now in the world's literature on the treatment of suicide. There are thousands of studies on the treatment of depression, right? So we are looking at a very under-researched topic for the magnitude of its impact. In treatment research, what our group does, what other groups do, is we really try to follow up patients as much as possible after the intervention. And so our typical follow-up is at 12 months, but we do time points at 3 months, 6 months, 9 months, and then we go out to 12 months. What I can attest to, at least clinically, and then in some of the studies that we've done, and we're still at this, is that we've seen meaningful impact on the majority of the patients. Now, some slip back, especially those who have made previous attempts. But those who are at the ideational level, we think we can meaningfully pivot them in a completely different direction, and they may never go back there.
Let's talk about a couple other related topics here. What's your relationship with the media and how suicide is presented, and whether that's helping or hurting your efforts here?
As with most things, it's mixed.
Yeah.
My view is that suicide and celebrity suicide can be a really hot story. But we've seen examples, and I'll be talking about it at the conference today, of, for example, after Kurt Cobain killed himself back in the 90s, the front man for the band Nirvana. We really feel that was a significant milestone in suicide prevention, because that particular suicide, big celebrity, big role model for a lot of kids, we think was handled remarkably responsibly by the media. Now, mind you, myself and some other people were involved with the mayor's office in Seattle and presented to the mayor's office the first generation media guidelines, to help sort of focus the message, to not sensationalize these suicides. But one of the things that you really noticed with that particular suicide was, years ago, if the media in newspaper or magazines or different kinds of stories, presented a topic like a celebrity suicide, there wouldn't be a box with hotline numbers, the National Lifeline number, or symptoms or signs of depression or suicide risk. And really, since that time, you saw that really becoming normative, that reporters have come to see that it is important to provide information about the National Lifeline number, about warning signs, about different organizations in suicide prevention, which I think is fantastic, and which I feel has made a huge difference in the reporting. And there was a time when reporters would say to people like me, I'm just doing my job. I'm just reporting the news. And I can't be responsible for bad outcomes. And then we showed them the data. And we showed them some of the copycat effects and some of the contagion effects that folks at the CDC study. And reporters started saying, okay, schools of journalism started saying, okay, we've got to be more thoughtful about this. We've got to be more responsible. So I think in many ways, the media can be a huge help. I think in many ways, the media contributed to the problem. And there it is. I mean, that's the tension, the struggle that we always deal with. I'm aware of, for example, the military suicide topic, an interest among some reporters to create a story, who have an agenda. And then there are some reporters who really just want to understand what's going on, what's happening. And so as an expert, I'm very sensitive to those pushes and pulls and feel that the American public has a right to know, but I really have strong reactions to the idea of making a story or creating a story or sensationalizing a story that may then create models, especially for young people, for example, that might create copycats.
The military, real quick, is there an attribution of the escalation due to being in active deployment so much versus times when there's less active deployment?
Yeah, I mean, we've always thought that combat in particular was suicide preventive, and in past wars we've really felt like that those soldiers and sailors and Marines that have been in combat have had lower suicide rates. Now they're a select population, right, because they're screened, they're selected, so they should have lower suicide rates, and that was true the first few years of the current conflicts. But the last few years, the numbers have really crept up, and for the first time in recorded history, infantry in particular, for the Marine Corps and the Army, have higher rates of completions than match cohorts who aren't in uniform. So this is shocking and very, very upsetting because it's always been protective to be in uniform. Select population, lots of support. Each branch of the military has large, significant suicide prevention programs. So we don't know what's up. There's a congressional task force that's really delving into this. I'm a member of that. We've spent the last year really studying. Is it multiple deployments? Is it the length of dwell time, the time between deployments? Everybody's looking at that very with a fine-tooth comb. We're really trying to understand what that's about. It seems like the deployments intuitively must make a difference if you go back 1, 2, 3, 4, 5 times, that there's a cumulative toll of that. But the data trails, as so many things in this field, and that's, I think, the definitive word on that is yet to be spoken, but intuitively, it takes a toll.
Is the screening different?
Screening is very much a hot topic, and how screening is done, when it's done, the quality of the screening is very much in focus as a contentious issue. But there are smart people and leaders in the military throughout the branches really looking at this and trying to figure out, are our screening procedures sufficient? Are we really catching stuff before it gets more problematic downstream? If we can catch it upstream and not let it unravel so much downstream or in the VA system, maybe we can do right by our troops.
So there's a couple other kind of population groups. Is there a culture difference between, say, high school youth and college youth?
The numbers are more higher for young adults, older adolescents, in comparison to younger kids, and so that early 20s range is this is a leading cause of death. I mean that, as the data go, elders have much higher rates, but it's not a leading cause of death. For kids, this is either the third or second leading cause of death. So yeah, there are differences in those cohorts, and we really watch that very closely to try to figure out what's up with that.
What about education levels?
You know, people have often said that suicide is a truly democratic thing. There's no group that's immune. There's no socioeconomic status. There's no educational status that isn't touched by this issue. There are protective factors. Being married, for example, is protective. Being divorced puts somebody more at risk. But in and of itself, those are not singularly causal. They're just correlates of completion data that we see retrospectively. But just having a good education, having a great job does not necessarily guarantee that someone can't get into trouble.
Another research-related question. You talked about being able to do research on people who are still alive. How do you do research on completed suicides?
The technique has been called the psychological autopsy. It's got its limits because the subject under study is unavailable. But there are relatively rigorous ways that you can do that well, through interviews, through looking through medical records in systematic ways. It's really been a very important tool, not just for research purposes, but also to linking surviving family members with support. So that's really our best angle. There are people that study suicide notes. It has sort of the last documents that reflect the mind of the suicidal person in the moments prior to their death. But you're appreciating, I think, one of the challenges of the field, which is that people we most want to study are by definition unavailable to us as subjects. So we can get more valid data if we talk to a very high-risk attempter who miraculously survives than somebody who makes a very low lethality attempt. But these are big challenges methodologically.
So you've had a lot of experience now. How do you see this field changing in the future? What do you think is going to be happening next?
This field is as dynamic as a field as I can imagine would be. There are many layers, many forces, public health perspectives, psychological perspectives. What I'm personally seeing, and it serves a bias, is less of a singular approach on taking medication and treating mental disorders as the way to clinically prevent suicide, which is not to say I'm anti-medication or anti-diagnosis, but you do see a lot more attention being paid to psychological factors and psychological treatments. Going back to the military or the VA, really what we're seeing with our veterans and soldiers is the best treatments for post-traumatic stress or for TBI, for traumatic brain injury or for suicide are these psychological treatments. And psychological treatments in combination with medication. So I think we're coming out of a period of time where we would just need to find the right gene or just the right combination or chemical, medical, pharmacological intervention to save lives. And I think we're not so preoccupied with that just yet, or maybe ever, as the singular way to address this. This is a human struggle. And yes, there are metabolites and there are hormones and there are neurotransmitters that are important and part of the picture. But that reductionistic approach, I think, is not at the forefront as it was even a few years ago, where people are seeing this much more in the complexity that it is, where that's a part of it, but where families, psychological considerations, cultural considerations, public health issues, stigma contribute to the whole picture. So if anything, I see the field picking up steam. I see a lot of people developing an interest in this. I see people in anthropology and in sociology and in psychiatry, getting involved with this topic. It's remarkably compelling. I get to be in a field where every day my job is trying to save lives. My day is trying to make an impact, whether it's with a patient or at a conference or in the professional trainings that I do, to give people who are in desperate states a second chance.
Thanks, Dave.
Thanks, Tom.
Folks, Dave mentioned the National Suicide Prevention Lifeline a couple of times here, and so if you or somebody you know is thinking about suicide, keep the number handy. It's 1-800-273-8255. Thank you for taking the time to take this program, and Dave, thank you for your time and your expertise.
Thanks, Ken.